Bismillah ar-Rahman ar-Rahim. Ma anzalallahu da'a illa anzalallahu shifa. Allah has not revealed any disease for which He has not revealed a cure. Viewers, I'm very fortunate again today that the world's renowned Professor Dr. Anthony Leeds has accepted my invitation to participate in the program. A lot of time will be required for the introduction of Professor Dr. Anthony Leeds, and his biggest introduction is, that he brings to us all the valuable opinion of the famous professors from all over the world for the awareness and treatment of various diseases for the sake of creation. We are all very grateful to him. Now, without waiting, let's go to the interview. Professor Dr. Anthony Leeds, first of all, I thank you very much for talking with us and for your talking time out of your busy schedule for us. My first question to you is, well over 2 million people have watched the first 4 episodes of the current series. What do we know about where these viewers are living, and does this help to prepare the program?
Yes, first of all, thank you very much indeed for inviting me to talk to you this afternoon. And as our very loyal viewers know, this conversation between us occurs in between the series of interviews with colleagues who are talking about very important topics. But the technical team have been able to analyze the information that is available and are able to tell us that the majority of listeners, the greatest number, are located in South Asia, Pakistan, India, Bangladesh. And then we have a large following in East Asia, and then also Southeast Asia is a very important area. And the reason why this is important is that when I'm actually preparing the programs, I brief the person being interviewed about the fact that we do have audiences outside of Europe. And also when I'm preparing the text that goes underneath the video recordings, I try to find sources of information which are relevant to those countries. And so it is very useful for me to know where our viewers are watching from, which countries they're in. But also, of course, the mere fact that there are so many people watching is very encouraging. And I must say that I'm very grateful to all of you for being loyal viewers, and I do hope they'll continue to watch. And I do hope also, if you've not actually used them before, please look at the text which is located underneath the video, and also the web links that are provided, which will take you to important and authoritative bodies in each of the countries in relation to the topic under discussion. Thank you.
I know that chronic degenerative diseases have always been your interest. Are there any common features in our 2 first topics, diabetes and age-related macular degeneration?
I think the important consideration here is the way in which we have approached the management of disease over the last 150 years. If you think back about 150, 170 years to the middle of the 19th century, the capacity of medicine was relatively limited in the sense that we did not have very much technology to apply to investigation of medicines. It was largely a question of an individual who had a problem, had a discussion with a doctor or a healthcare professional. They talked about the symptoms. There was a physical examination. Some relatively elementary tests might have been done on whatever was available, blood or urine. But it was not until the development of chemistry in the second half of the 19th century that we were able to begin to do chemical tests. And then, of course, as we moved into the 20th century, these became much more sophisticated. And, of course, with the advancement of technology throughout the rest of the 20th century and into the present century, what we can do now is very much more sophisticated and gives us much more information than was the case in the past. As a consequence, the classification of disease has changed, and also, of course, the pattern of disease has changed, and everybody knows that there's been a rising prevalence of conditions like heart disease and cancer and obesity and diabetes, and these are the chronic degenerative diseases, and these, of course, cause a great deal of human suffering and also cost a lot of money to manage where those resources are available for healthcare. What I would like to see, and I know that all of my colleagues working across the globe would like to see, is that we perhaps begin to look earlier in the development of a disease so that we can detect it sooner and perhaps intervene in ways which slows down the way in which a condition progresses. So we catch young people who are becoming heavy early on so that they don't become very, very heavy, and that we catch people who have eye disease at an early stage, and where we are able, and it always has to be based on very good science, of course, where we're able to do so, we would give the appropriate treatments well in advance. And we discussed with John Nolan in Waterford in Ireland the possibility of using dietary pigments for slowing down the progress of age-related macular degeneration. And with regard to diabetes, we know that the majority or a big proportion of people who have type 2 diabetes, which tends to occur later in life, although now it's occurring in much younger people, is related to the changes in the metabolism, which is very strongly related to being too heavy, having fat in the wrong places. And Professor Mike Lean discussed the present position on the evidence which tells us that by achieving weight loss, we can actually put recently diagnosed type 2 diabetes into remission. And this is a major achievement. This is changing the pattern of the approach to diabetes across the globe. Both of those are examples of chronic degenerative diseases where, by knowing more about how the disease develops and how we can interfere with the process, enables us to intervene earlier. What I would like to see is us doing very much more of that across the whole spectrum of chronic degenerative disease.
Thank you very much, Doctor. Now I'm asking a very important question to you. What would you like to see happen next in relation to the global role out of diabetes remission programs?
Well, interestingly, I've spoken with my colleagues very recently about this, and we're already applying this in other countries. For example, there is a paper in the pipeline that describes a diabetes remission program for Nepal. We have programs up and running in a number of countries in the Middle East, in Australia and New Zealand, and each of these will be reporting in due course. So it's already happening. Essentially, we would like to roll this out so that losing some weight becomes the first thing that is done when a person develops a diagnosis of diabetes. However, it is also known, and it's not a new fact, it's been known for a very long time, that if you take individuals who are at risk of developing diabetes, and then you achieve some weight loss, and you can maintain that weight loss by 4, 5 or 6 kilograms over a period of 3 years in some studies, 5 years in others, we know that the people who can maintain that reduction of weight actually are less likely to develop diabetes. And that really is effectively primary diabetes prevention. And since we know that global populations in every country in the world, there are people who are much heavier than they should be. We know there's a drift upwards in weight in almost all countries in Western Europe of perhaps 10 kilograms, 15 kilograms over 10 to 20 years. We know that everybody would benefit to some extent from some weight reduction. Now, we also know that the metabolic changes associated with obesity are also driving high blood pressure, heart disease, and also quite probably the risk of developing cancer. So that it's so obvious what we should do, and the real thing is to work out how we can get it to happen. There's a very long delay usually between finding out what you need to do and then actually getting it in place. However, the United Kingdom, as you know, now has a pathway to diabetes remission program, which seems to be working very well, and other countries are doing the same. So what I would like to do is more of the same, but also apply this same process, this digitally delivered dietary program, for other conditions which are associated with obesity. So, for example, osteoarthritis, which is a topic on which I've worked with colleagues in Copenhagen for some years, and we know that good weight losses there are also effective. And when you think of the numbers of people you know, particularly older people who have well-developed osteoarthritis, if they can lose weight, they may well be able to reduce their pain. They may become more mobile. They will, when looked at in detail, you'll find out that their quality of life is much better. So I think there's an application there. We've done work on this in Edinburgh and Leeds, and the evidence suggests that it would be relatively straightforward to roll out the same type of program for osteoarthritis. And then there are other conditions as well. So there's a great deal to do, but essentially we know what to do. We just need to get on and do it.
Can you kindly tell us, some reviewers, that what would you like to see next in relation to nutrition? eye health and the brain health?
With regard to the work that John Nolan discussed with us, I think what is required is that often in these situations it's a question of educating people about the knowledge which is now there and informing people about how they can reduce the risk. You recall that when he and I discussed this, I asked at the end, what can ordinary people do, perhaps even people who don't have access to eye health services? And we discussed the way in which we know in most of these conditions what the risk factors are. So, for example, we know that smoking is a risk factor. We know that diet is highly relevant, and I gave some examples of the types of foods that contain the pigments which, when consumed sufficiently and absorbed, can improve the state of the back of the eye and the ability of the back of the eye to be protected against oxidation, which is the mechanism underlying the problem. So we can give information. And then, of course, people have got to actually follow the guidance given. Now, everybody knows that smoking is something that occurs in all countries in the world. In some countries, it's been reduced greatly. It is tobacco smoking, of course, but in others, less successfully. And an individual has to decide whether or not they want to make those changes in order to reduce their risk of developing a condition. You will recall also that when we were discussing eye disease, we mentioned that there are genetic factors. There are some individuals who are more at risk of developing this condition than others. And it's the people who are at risk who really need to take note of that diet and lifestyle guidance. And for those who are interested, they may like to look back at the text that I provided and the web links that I provided underneath the video.
Professor, actually, this is my last question for this session, actually. So who will be your next guest? Is that a question? And who will be your next guest, and what topic you are going to discuss anymore?
Well, as viewers know, the last two episodes, I interviewed one of my colleagues, bariatric surgeon, Mr. Pratik Sufi, and we discussed the use of bariatric surgery for managing obesity. And in a sense, that's an example of the way in which the treatment, the surgical treatment, is applied further on in the disease process. In other words, we didn't catch those people early enough to be able to stop them gaining weight, and they've got to a point now where they are affected by A, being heavy, and B, having some disease associated with being heavy. Bariatric surgery is a very, very effective intervention. I've worked with Mr. Sufri for a number of years, and we know that you can transform the lives of people who have had bariatric surgery. However, it is an example of where you are treating the disease process towards the latter end, towards the end of the condition rather than early on. So he spoke last week and the week before. I'm going to be able to talk to John Nolan's colleague, the geriatrician, who worked with him in Waterford. So there'll be another program about dementia. And then Professor Roy Taylor, who works at the University of Newcastle, is going to talk about the underlying mechanism that's involved in the diabetes remission programs and the way in which, by reducing body fat, you can actually reduce liver fat and pancreatic fat and get some degree of recovery in the pancreas. So he will discuss that in detail. So you can look forward to those two episodes shortly.
Dr. Leeds, thank you very much for talking to us today. We will, before we're leaving the program, actually, let I tell you one thing, actually, that the preparation of this, all these programs require a lot of effort. Of course, it's not a small task to take time from Dr. Anthony Leeds, research and related special professors from around the world to treat these diseases, for which we thank all those people. We also request you to help us in this publication of these programs. Be sure to share the link of these videos to all your friends, relatives, so that they can also benefit from it. We will also be waiting for your kind and precious comments. Thank you very much, and watching for this was the program. And Dr. Leeds, again, I'm very thankful to you. Thank you.
Okay, it's my pleasure. Thank you very much. Thank you.